All right, so we'll go ahead and get started. Hi, everyone. My name is Twin. I am the program coordinator for Community Health Resource Center. You can find my email on the screen right here. I am the program coordinator for both health education and health screenings. Of course, what you are participating in right now is our health education program. A little bit about Community Health Resource Center. We are a nonprofit affiliated with California Pacific Medical Center. We've been around for over 30 years, and we provide two main areas of service outside of health screenings and health education, making a total of 4, but the other 2 areas are nutrition counseling and mental health services. We are also accepting appointments, so if you are ever interested in nutrition counseling, such as medical nutrition counseling for cancer, transplant, diabetes management, or just simple disordered eating, not that it's simple, sorry, give us a call or an email. Dr. Benson Chen has been providing care for over 20 years, and he is an expert in lung cancer screening and lung nodule management. He is also a faculty member in pulmonary disease and critical care medicine at CPMC and Alameda County Medical Center. Dr. Chen, I will pass it on to you now. Thank you. You all might notice that you won't be able to see Dr. Chen, but you'll be able to hear him pretty clearly.
Yeah, actually, that was a very flattering photo. I look much different now, about 15 years later, so thank you. I just want to thank Twin and CHRC for allowing me to speak to you guys. This is a very important topic for me personally and also professionally. It's a devastating disease, lung cancer, but things have changed and improved so much in the 20 years that I've been practicing medicine. It's almost unimaginable. Compared to what I had learned initially when I was in training. So definitely feel free to reach out and ask questions. I will try to make this as informal as possible. Okay, so just talking about disclosures, I do own some stock in GE. It's done horribly, so it's not even worth talking about, but just in case you were worried about my disclosures. So let's just talk about lung cancer facts. I don't know if you realize it, but lung cancer still is the #1 cause of cancer-related mortality in this country for both men and women. More people die every year of lung cancer than colorectal, breast, and prostate combined. So while you see tremendous amounts of advertisements and advocacy for breast cancer, prostate cancer, and colorectal cancer, and while more people have those cancers than lung cancer, more people die of lung cancer every year compared to those 3. So it's a devastating disease. With regard to causes for lung cancer, the predominant cause is smoking. This graph is a little bit confusing because if you add the percentages, they come up to more than 100, but it's more that there's some overlap in individuals. But the point of the graph is to show you that the overwhelming majority of patients who develop lung cancer, they do have an active smoking history or can be, or if you delve into it, they have had a significant history of smoking in the past. There are individuals who have had no smoking history, and we can talk about those patients later. But the focus on this talk is going to be those individuals who've had a heavy smoking history. And so if you look at patients, with regard to prognosis, you can see that, stage really matters. If you are diagnosed with early stage disease, prognosis at 2 years and 5 years is quite good. So stages 1A, 1, 2, and 3, prognosis at 2 years and 5 years is mostly over 80%. And so super important for us to try to figure out a way to detect lung cancer at an early stage if we can't prevent it. So if anyone has any questions, definitely stop me because I speak very quickly and we'll be done this presentation very quickly if no one stops me. So this is much more information than you need to know, but this is how we come up with those stages. So if you can see the pointer, these are the different types of T staging: T1, T2, T3, T4. If you are interested in specific descriptions about them, you can look down here and they'll tell you exactly what they are. N is for nodal staging, how far, what area lymph nodes are involved. So N0, N1, N2, N3. And if there's evidence of metastatic disease, so outside of the chest, you can see, those descriptions there. And you can see over here on the right side that, even for metastatic disease, not all metastatic disease is created equal. So if you have M1C, meaning that you have multiple foci of metastatic disease, your mortality is exceptionally high and very, very, and your life expectancy is very short based on that information. Here's a question. Oh, sorry, metastatic. Metastatic disease is when cancer has spread away from the original site of origin. So if we're talking about lung cancer, metastatic disease can be in this M1A, it can be to the other side, other lung, or it can be outside of the lung, to the brain, to the liver, to the adrenal glands, etc. Are there other questions? Okay. I think. Got it. Okay. So this is a graph of lung cancer diagnoses, so rate of new cases and death rate. And it's encouraging. If you look at the number of cases that we're diagnosing, they really seem to peak in the 1990s. And then since then, it's started its slow creep down. And so, we're close to where we were back in 1975. And if you look at death rate or mortality, it again peaked about the same time and has come down. And while this is encouraging, this to me speaks more of the effectiveness of people not smoking, so never starting smoking or quitting smoking. Because if you look at the difference between new cases and death rates, they're not very different, at least not appreciably at this point. So while we're very good at improving survival from lung cancer, we still are not very good at detecting it early enough to provide a cure for the majority of individuals. Though we'll talk more later about how that might be changing. So this is one of the reasons why we might be able to detect lung cancer earlier, is that lung cancer screening with low radiation dose CT is effective. This was revealed in a New England Journal paper in 2011. This was a very large study that we'll talk about in a little bit more detail in a few more slides. And it was approved by the U.S. Preventive Services Task Force in August of 2013 to be funded or paid for by insurance. So as long as you meet the criteria for lung cancer screening, we can offer you a screening test to try to detect lung cancer early enough that we can actually save lives. In addition, because smoking is one of the biggest causes of lung cancer, we oftentimes are stuck in a situation where somebody may actually be a candidate for surgery, but because of the severity of lung disease from smoking, they aren't a candidate for surgical resection, so curative therapy. But it turns out that stereotactic radiation is a type of treatment that actually can be curative if the cancer is early, meaning it hasn't spread anywhere beyond where it started. So no lymph nodes are involved, et cetera. And it's actually the first-line option for therapy for individuals who are not candidates for surgery because their lung disease is too severe to allow us to remove portions of lung, or because of other coexisting medical conditions. So there's a question asking, are screening tests usually covered by insurance? And the answer to that is yes, but it depends. You have to qualify, you have to meet the criteria for screening, and we'll go through that in a little bit. So in addition, if you have advanced stage lung cancer, meaning that we don't have a curative therapy available for you, we actually now have more effective treatments. So there are things that are called targeted therapies. So if you have an advanced stage lung cancer and you have your oncologist should be looking for different types of targets that different treatments can go after. So some of them are listed here: EGFR, EML4-ALK, ROS1, BRAF. There's also the possibility that the lung cancer is successful in being, spreading throughout the body because it's able to dodge the immune system, and so the immunotherapies are designed to basically refocus your immune system to be able to attack lung cancers that have been able to dodge your immune system. So we're excited about these therapies, and they're continuing to be developed. For a while, it was so exciting because it seemed like every few months a new treatment was being proven to be effective in helping to treat people with lung cancer. There's another question. If a family member died from lung cancer, does it increase your risk? Yeah, it does, and it's hard to quantify that risk, but it does. We do factor it in as something that is a risk factor for lung cancer. Okay. In addition, we have new, less invasive, more accurate diagnostic tools than we did 20 years ago. So today we use PET-CT. PET-CT is positron emission tomography with computed tomography. This is a type of test that helps us determine how metabolically active particular lesions are in the body. And so it's very helpful in allowing us to determine, what other sites might be involved if you do have lung cancer or if we suspect that you have lung cancer. So that way we can target a specific area for biopsy that will provide us with a diagnosis, also provide us with how advanced the cancer is, and also provide us with the ability to send tissue for different testing to determine what are the best treatments that we can provide. Sorry, there are more questions. So these other questions I'll answer later because I think these are from CHRC.
So sorry to interrupt you, Dr. Chen.
No, it's okay.
But no need to answer them as you go. If you can also wait until the end if you'd like.
Okay.
In case unless you want to. It's all up to you.
Okay. Sounds good. I'll defer those two questions that are up right now to later. EBUS, or endobronchial ultrasound, in my opinion, along with endoscopic ultrasound, or EUS, have revolutionized how we manage patients with lung cancer. Prior to the development of these two types of procedures, in order to determine whether the lymph nodes in the patient's chest are involved with cancer, we would oftentimes have to resort to surgery. We would actually have to ask a surgeon to make an incision at the base of the patient's neck and insert a scope behind the breastbone along the windpipe, looking at lymph nodes as they move down into the chest, and sample them to see if there's evidence of cancer. And that was a very invasive procedure. It was a day procedure. You go home the same day. But it was something that basically was, pretty uncomfortable. And with endoscopic ultrasound, EUS, and endobronchial ultrasound, These are procedures that gastroenterologists or GI doctors and pulmonologists or lung doctors perform. We put scopes into either the windpipe or the food pipe, and using ultrasound, we can find these lymph nodes and actually biopsy them under real-time imaging so that we can accurately determine whether there's involvement of lymph nodes with cancer. In addition, with CT, computed tomography imaging, we can do great biopsies of lung lesions without having to open somebody up. And more recently, in the last 15 years, we have now gained access to imaging-guided bronchoscopy. It's almost like GPS for the lung, where we can maneuver catheters through the airways with a bronchoscope to biopsy lung nodules. So much easier than 20 years ago, when if we wanted to get into the chest, sometimes we would actually have to go in and open people up to biopsy. There's a question just submitted. It says, when you say lung cancer has the highest mortality of all cancers in the U.S., are you describing primary lung cancer? Yes. Lung cancer as a primary disease, more people die of lung cancer every year in the U.S. than prostate, breast, or colon combined. And then the other thing that has become important and that people have recognized is that physicians are more aware that lung cancer is a disease that is best managed by a multidisciplinary team. Multidisciplinary meaning that the group of individuals who are taking care of somebody with lung cancer are composed of individuals from multiple specialties. So from pulmonology or lung disease, medical oncology, radiation oncology, thoracic surgery, radiology, palliative care, and social work and nursing. So having individuals from all of these different specialties and areas of expertise really provide a well-rounded perspective in helping patients manage their disease and basically try to optimize all of the different technologies and treatments that we have available. So we go back to the original concept or topic of the discussion, which is lung cancer screening, and this is not to try to quote Shakespeare, but to screen or not to screen is the question. And so I'd like to just use a patient case. So there's a 55-year-old woman who is actively smoking. She has a 30-pack-year tobacco history, and that means that individual has been smoking a pack a day for at least 30 years, or has been smoking 2 packs a day for at least 15 years, or she's not old enough, but a half pack a day for 60 years. So you just multiply the number of packs per day by the number of years that you smoked, and that's your pack-year history. Her physical exam is unremarkable, which is important because you shouldn't be doing screening in somebody who actually has lung symptoms, because you should be doing other workup to try to figure out why they have symptoms. And the patient has one question: should she undergo CT screening for lung cancer? So in my perspective, lung cancer screening, if it's going to be effective, it really has to accomplish 2 things. We have to, number one, if we're screening patients, we have to be able to reduce the number of patients who actually present with advanced stage lung cancer, right? So if you're detecting lung cancer at an early stage, that means that you're taking those patients out of the pool of individuals who are going to go and develop lung cancer. So if you've detected it at an early stage, then the number of patients who present with late stage disease should decrease. And as important, you should improve the mortality or death of patients from lung cancer, as well as from all causes in those patients who undergo lung cancer screening. So the National Lung Screening Trial was a very, very large study that was sponsored by the National Cancer Institute and completed enrollment in 2004. They ended up enrolling 53,000 patients across the United States, and they compared low radiation dose CT, which is an effective radiation dose of about 1.5 millisieverts. The amount of radiation we get on average every year just by living, traveling, et cetera, is about 3 millisieverts. So they compared giving patients an annual, so once a year, low radiation dose CT with a chest X-ray once a year. A chest X-ray, the amount of radiation you get from that is about 0.06 to 0.1 millisieverts. So in order to be included in the study, you had to be between the ages of 55 and 74. You had to have a 30-pack-year smoking history at least. And if you were a former smoker, you had to have quit within the last 15 years. So if you quit 16 years ago, you weren't included in the study. You were excluded, you weren't allowed to participate in the study if you had a previous diagnosis of lung cancer, if you had had a CAT scan within the last 18 months, if you had hemoptysis, which is coughing up blood, right? Because if you're coughing up blood, you should probably be evaluated for that, which could be due to lung cancer, instead of being enrolled in a lung cancer screening study. And if you've also had unexplained weight loss of more than 15 pounds in the preceding year, again, if you were losing weight and you can't explain why, then you need to have a workup for cancer. So you should not be enrolled in a lung cancer screening trial. So the results are really interesting. So if you can see my pointer again, these 4 columns describe the patients who had a low-dose CT scan. These 4 columns here describe the patients who had a chest X-ray. T0 is the very first year that you were enrolled in the study. Okay. T1 is the following year. T2 is the year after that. So people only had 3 images total in this study. And I want you to just focus on the total numbers here. So the number of positive tests in the CT scan group was 18,000 compared to 5,000 in the chest X-ray. And the reason is that CAT scan, CT scan, is very, very detailed in its pictures. So you can pick up very, very small lesions that you would not be able to see with chest X-ray. So that's the reason why so many more lesions, more than 3 times the number of lesions were found with CAT scan imaging compared to chest X-ray. But here's the problem. So even though there were more cancers confirmed, 649 compared to 279, the number of people who did not have lung cancer was very, very high. 17,497 patients did not have lung cancer out of that 18,146 that had a finding that was concerning for lung cancer. So only 3.6% of patients with a finding that was concerning for lung cancer, 3.6% total, had lung cancer. So it's what we call a very, very high number of false positive findings. Falsely positive, 18,146 patients had findings that were concerning for lung cancer, so that's a positive finding. But 17,497 of them did not have cancer, so that's a false positive finding. So how many of those patients with these findings had a biopsy or some sort of procedure? 10,430 of them. So 58.9% of patients with a finding ended up having some sort of procedure to try to figure out what that finding was. And again, only a very small percentage of them actually turned out to have lung cancer. So a lot of patients had biopsies who didn't need them. They needed them because the findings were there, but the biopsies were not conclusive for cancer. And those patients who actually needed to continue to have other imaging follow-up, that was 12,757. So a large number of patients still had to continue to have workup of those nodules or those findings just because of the possibility that you could end up having cancer from those positive results. So the incidence of lung cancer in the CT arm, there were 1,060 lung cancers eventually detected, so 645 cancers per 100,000 person years, compared to the chest X-ray group, which is 941 or 572 per 100,000 person years. So that's the number of people and the number of years that they were followed. That's how they got that number. So it was definitely effective in detecting more lung cancer. Now here's that first requirement that I talked about, which is that you really need to, with screening, find cancers early enough that you end up decreasing the number of patients who are found with lung cancer at advanced stages. So what we describe as early is stages 1A through 2B. So 1A, 1B, 2A, 2B. And advanced stages 3A, 3B, and 4. So I drew a line across this table. And this is the group with low-dose CT, and this is the group with just chest X-ray. And you can see that early stage disease was 40%, 10%, 3.4, 3.7, compared to 21%, 10%, 3.4, 4.5. And for advanced stage disease, so let's take the worst, metastatic disease at 4, 36.1% compared to 21.7%. So there was a move towards earlier stage at diagnosis compared to advanced stage disease in people who underwent lung cancer screening with CT. And then let's talk about death from lung cancer. So they followed patients out over 7 years, and they found that, even though they only screened people out to 2 years, because there was only 3 scans done, right? So you can see that very early on, the red line is people who got chest X-ray, the black line is people who got CAT scan. Very quickly, you found more lung cancers in the CT screening group compared to the chest X-ray group. And that number continued to increase even though the study stopped at year 2. And then only at about 6 years did it start to flatten out and become essentially stable. And then with regard to death from lung cancer, so the higher you are on this graph, the more deaths that you're looking at. So more people died in the chest X-ray arm compared to the CAT scan arm. So it is effective as a screening tool in the sense that it, if we go back one slide, it did detect more people at an earlier stage and ended up decreasing the number of people found at an advanced stage, and also decreased death from lung cancer with time. So again, increased detection of lung cancer with annual low radiation dose CT screening. So 645 versus 572 per 100,000 person years. You had decreased lung cancer related mortality, 247 people versus 309 per 100,000 person years. That gives you a relative reduction in lung cancer mortality of 20%. So if anyone's been paying attention to the news, this is where they came up with that 20% reduction in death from if you do lung cancer screening. And there was also a 6.7% decrease in death from any cause for people who underwent lung cancer screening. But the big issues are that you have a high number of false positives. So 96.4% of the findings that are concerning for lung cancer turn out not to be lung cancer. There are also, interestingly, a significant number of cancer diagnoses made after the final screening CT was performed. And it's presumed that these are just findings that were detected during the screening that then required further follow-up imaging over time. And so it just took time for those patients to be eventually diagnosed with lung cancer. And the other thing is that the evaluation of positive findings was conducted at centers with experience and expertise in the management of patients with lung nodules, lung masses, and lymphadenopathy. Lymphadenopathy is just having lymph nodes enlarged. And so it's very hard to generalize these types of results to any Joe Schmo person who's out there performing lung cancer screening. So it really requires this multidisciplinary team to make sure that these patients are actually getting very, very thorough evaluations and accurate follow-up imaging and biopsies when appropriate. In addition, costs associated with screening are high. I'm not talking necessarily about the cost, the financial cost of obtaining a scan. It's also, the psychological toll of being told that you have something in your lung that may be suspicious for lung cancer. But the problem is that that many of these lesions that are found are super small. And so unfortunately, and this is in no way to detract from, skin cancer, breast cancer, colon cancer, cervical cancer, but the reality is that, if you are told that you have a breast lump, you go and get a biopsy. There's no questions about that. You just go in and have a needle put in, or someone just cuts the skin and pulls out the lump. If there's a cervical concern, a cervical lesion, you go for a colposcopy or you go for a biopsy of that lesion. If there's a colon polyp, you just go and have that resected. But for lung cancer, for lung nodules, trying to do those biopsies can be very, very difficult. Putting a needle in someone's chest can result in lung collapse, bleeding, infection, end up being in the hospital. Trying to remove a lung cancer itself or a nodule, if you're worried about the possibility of lung cancer, the surgery by itself can be associated with a 1% to 2% risk of death. So a much bigger risk associated with trying to address what abnormal findings are in the chest compared to anywhere else in the body. So someone asked, does CPMC prefer CT scans or chest X-ray for initial screening? So the answer to that is it's actually the same everywhere in the country. CT scanning is the preferred. It's actually the only way to do screening for lung cancer. Chest X-ray was proven in the 1970s to not be effective in lung cancer screening. So you should not be having chest X-rays for lung cancer screening. It provides you with exposure to radiation without improvement in mortality or death. So back to the presentation. So CT screening, other issues, radiation exposure is not trivial. So again, the low-dose radiation CT is 1.5 millisieverts. A PET CT, which I discussed earlier, that can be as high as 15 millisieverts of radiation for one scan. A routine diagnostic CT can be as high as 7 millisieverts of radiation. And again, a chest X-ray tends to be on the lower side at about 0.1 millisieverts. And the relative or the reference point is that we all receive about 3 millisieverts of radiation per year. I think someone else asked another question. Oh, I'll answer that later. Okay. So number needed to treat. So this is something that a lot of people like to use to help you understand how many people need to undergo screening or a test or whatever to save a life. So for lung cancer screening, using the data from the National Lung Screening Trial, we have to screen 217 patients to prevent one death. But just for comparison, breast cancer screening, you need to screen 781 patients to prevent one death. Colorectal screening, you need to screen 1,250 patients to prevent one death. So when you look at relative numbers, actually lung cancer screening is pretty good. But again, 1 in 4 patients had a false positive scan. 1 in 30 had unnecessary surgery, and 1 in 161 had a complication from that surgery. So this is not something to embark on lightly. So more recently, another lung cancer screening trial was published, and this is one that was done in the Netherlands and Belgium. So this is the largest European trial. It's called the Nelson trial, and they enrolled almost 16,000 current or former smokers. And these individuals actually didn't smoke as much as the individuals who were in the NLST trial. So these are individuals who smoked greater than or equal to 15 cigarettes a day for more than 25 years, or greater than or equal to 10 cigarettes a day for more than 30 years. But if they had quit smoking, they had quit less than 10 years ago, so a shorter time since they quit smoking. Compared with low-dose CT, they compared low-dose CT with no screening. And their interval of imaging was not every year. So there was the first screen was done, first interval was done at 1 year. The next one was done 2 years after that. So now you're 3 years in. And the following study was 2.5 years after the prior one. So now you're 5.5 years into the study. It was powered to detect a 25% decrease in lung cancer death after 10 years. So at 10 years for men, it decreased death by 24%, and that's statistically significant. For women, it had a dramatic effect of 48% reduction in death at 9 years, but for some reason at 10 years, it was not significant. So even though the relative risk was 0.67 or about 33% risk reduction, when you looked at the range, what we call a 95% confidence interval, it spanned 1, so 0.38 to 1.14. So whenever you have a statistic that spans 1, it means that it actually wasn't effective. So it's unclear how to interpret that for women, but at 9 years, it's effective. At 10 years, it doesn't seem to be. So in this study, in the screened group with CT, 344 lung cancers were found. 59% were at stage 1, 9% were at stage 4. And in the unscreened group, 304 lung cancers were found. 13.5% were early stage at stage 1, and 46% were at advanced stage or metastatic disease at stage 4. So it was effective in the sense that it decreased mortality and also tended to detect lung cancer at an earlier stage. So this is a super complex slide, but basically the conclusion is that low-dose CT is an effective screening tool for persons at high risk for lung cancer. The problems and the things that you have to keep in mind is that the interpretation and evaluation of the CT results should be performed by a multidisciplinary team of physicians with expertise in the management of lung nodules and lung cancer. How cost-effective this is, how cost-effective CT screening is outside of the clinical trial is unclear based on the high number of false positive findings. So we don't know if this is cost-effective, and part of the issue is that cost-effectiveness can be very controversial. It basically says how much money should be spent to save a life, a year of life, and how do you put a dollar amount on that? So we won't go into that. I'm not about to try to open up that Pandora's box, but there are debates that are ongoing about that in the scientific community. And follow-up for people who undergo lung cancer screening, should be using this chart, and it's called lung RADS. And basically, this helps us to determine, how concerning an abnormal finding is. What type of interval follow-up imaging should be done, and whether someone should go for biopsy or not. More questions. So vaping and smoking cigarettes, I'm not going to go into that right now. And an itchy feeling in the lungs, that's a whole different discussion, so I'm not going to answer that one either. That's a completely different problem. Okay, so let's go back to the case. So the patient, after going through the clinical trials and the reasons for doing lung cancer screening, decided to have a screening chest CT. So as I mentioned before, screening detects a lot of abnormalities. So the total number of patients who had an abnormal screening was about 24% over 3 years. And so most of these findings are lung nodules. And lung nodules are basically little densities within the lung tissue, and officially they are measured at less than 3 centimeters or less than 30 millimeters in diameter. So with lung cancer, with CAT scan imaging, we are detecting so many lung nodules that many providers are overwhelmed with the number of patients who need to be seen for follow-up. And in certain lung cancer screening trials, up to 51% of individuals who are at high risk for lung cancer can actually have lung nodules. So it can be a very challenging problem because, again, like I said, you'll have a patient who comes in with a lung cancer screening CT, and then we have to tell them, oh yeah, we did find something, and the psychological toll that takes on an individual can be quite significant. So sorry, there's a few more questions here. So someone typed, would you say that lung cancer screening is the most difficult to screen for? it's the most difficult in the sense that the evaluation of abnormal findings is more complex than with any of the other cancers. Other cancers, a biopsy, while it can be inconvenient and uncomfortable for the patient, is actually relatively straightforward and of relatively low risk to the patient when compared to trying to evaluate something in the lung. I hope that answers that question. What innovations in lung cancer screening and treatments is CPMC currently testing or using? There's a huge gamut of things that we're using currently. So we do CT-guided biopsies. We use the whole gamut of bronchoscopic techniques. Bronchoscopy is where we put scopes through the mouth or nose down into the lungs. We use ultrasound scopes. We use robotic scopes. We use navigational scopes. We actually can put scopes in through the chest wall into fluid that surrounds the lung, looking at the fluid to see if there's cancer there. We are participating in a clinical trial right now where if an individual has a lung nodule that's concerning enough for cancer that we're going to send them for biopsies, we are asking patients to enroll in a study where they would get a blood test, and the blood test would basically be analyzed for proteins that might help us detect or predict whether a lung cancer exists. So there's a whole slew of different things that we're doing, but maybe we can discuss that in more detail later. So I'll click that one out. And okay, I think those are the questions that I'm going to answer right now. So the differential diagnosis. So this means like what could a lung nodule represent? So the list here is not complete, but it provides a pretty good overview. And the point of this is not to have people sit there and look at it and try to memorize it, but more to understand that what we find in the lung could be anything from an infectious cause to a cancer to something that's related to inflammation or to an autoimmune process, to something that is miscellaneous, meaning that like maybe someone choked on a BB and it's sitting in the chest, or it could be that it's just scarring related to a prior pneumonia that you had. So it does require somebody who is aware of all the different possibilities and isn't thinking that everything in the lung that's abnormal is cancer. Because if you are being managed by someone with that approach, you're going to have a lot more biopsies that are not really needed. And as a result, with every biopsy comes a risk of complications, and so patients can end up suffering a lot more harm than benefit over time. So the most important question that we have for individuals, patients who come in with an abnormal finding such as a lung nodule, is do you by any chance remember having old imaging? So if you've had an old chest x-ray or an old CAT scan, it is so important for us to have access to that, to the specific images, because unfortunately I don't trust anybody else's view or review of imaging. I like to see them myself. But it's so important because if something has been present for at least 2 years and has not changed in that 2-year period, it suggests that it's not cancer. It's unclear if it applies to a very particular type of abnormal finding called ground glass. But for everything else, if it's been there for 2 years at least and it's not changed, then it would be highly, highly unusual for it to be a lung cancer. In addition, we're also looking to see if there's a pattern of calcium. So calcium on imaging shows up as a super bright white picture. And so I've given some examples of the types of calcification patterns that are suggestive of benign or not cancerous disease. So there is diffuse calcification. So if the entire lesion is calcified, then that's not cancer. If the calcium is located exactly in the middle of the lesion, then that is not suggestive of cancer. If the calcium looks like popcorn, like a popcorn kernel, popped popcorn kernel, inside the nodule, then that is very highly unlikely to be a cancer. And if it's got these concentric rings of calcium, it is also very unlikely to be a cancer. And so the other important point is that 7% of calcifications that are seen on chest X-ray are actually not detected on CAT scans. So depending upon what we see on chest X-ray, we may still want a CAT scan to confirm that that finding is present. So again, for the evaluation, size matters. So the risk of cancer increases with the increasing size of the lesion. So if the lesion is less than 3 millimeters in diameter, the risk of that being a lung cancer is exceptionally low, even in someone who's a heavy smoker. The risk is 0.2%. If the nodule is between 4 and 7 millimeters in diameter, the risk is 0.9%. If it's 8 to 20 millimeters in diameter, the risk is 18%. If it's greater than 20 millimeters in diameter, the risk goes up to 50%. But the problem is that if your lesion is small, our tests are not very accurate in trying to help you determine the severity of it or even to diagnose it. So PET, that test that I talked about earlier that helps to decide how active something is, it's not very active for things that are smaller than 8 millimeters in diameter. So if it's less than 8 millimeters in diameter and the PET scan comes back negative, meaning no increased activity in that lesion, it means nothing. It doesn't tell us that that thing is not an aggressive cancer. An attempted biopsy with CT, a CT-guided FNA or fine needle aspirate, is not very accurate if the lesion is less than 1 centimeter in diameter. The radiologist has to put a needle through your chest into this lesion, and that lesion may be moving depending upon where it is in your chest. So if it's very small and your breath moves that nodule more than the diameter or the size of the nodule, you can imagine how hard it can be for a radiologist to put a needle into it. And as they're putting a needle into it, they're running the risk of collapsing your lung. So we don't want them sitting there sticking needle after needle into your chest and missing the lesion over and over again. And then wedge resection. So this is when we ask a surgeon to go in and just pluck out that nodule by cutting it out, cutting a small piece of lung out. I've actually seen a surgeon go in to try to resect a nodule, and when we repeated the scan after the surgery was done, the nodule was still there. So the surgery completely missed the nodule, and that can definitely happen if the nodule is small. You got to understand that the surgeon is in there because the nodule is below the surface of the lung. They're trying to find the nodule by looking at the surface of the lung. So sometimes they'll try to put their hands in there and use their fingers and rub the surface of the lung to see if they can figure out where it is underneath. But if it's a soft lesion or if it's very small, you can imagine how that could be missed. It's the worst case scenario that you put someone through the risk of a surgery and you end up not even cutting out the thing you wanted to remove. So nodule characteristics, ground glass is something that is basically what we think about. The best way to describe it is it's a kind of a hazy, light-colored lesion within the lung, but you're able to define or determine or see the architecture of the lung underneath. Partly solid is where you have parts of the lesion that are dense and completely white and completely obliterate the underlying architecture, and part of it that's ground glass. And then the other type of lesion if it's purely solid. So you just see this white-looking lesion, and there's no obvious architecture underneath. All of these, I don't find these three to be particularly helpful in the sense of that one is more likely to be cancer than another, but these are the types of things that we see within the lung. Nodule surface, so all of these can be related to lung cancer, but when you describe spiculated, that's a term that can be very scary for us, because when we hear that, we get very worried about lung cancer. And so the way I like to try to explain what spiculation is if you guys just take a cheesecloth flat on a table, and you use your fingers and grab a portion like in the middle, and you bring your fingers together, and you can sort of imagine how that pulls little lines or pinches together the cloth around it. It creates these little lines that kind of spread out from it. That is the spiculation, sort of a starry pattern around it. And so the thought is that as a cancer is growing, it's sort of bringing in the surrounding lung tissue and creating that tethering effect that then creates these lines that spread out away from it. So that's a very concerning finding for a nodule, but it's also something that can be misleading, because if people have very bad emphysema or COPD, there are all these pockets or holes around the lung, and so if you have a density that is just tracing the lung tissue but not in the airways, it can also give you the impression of spiculation. So we oftentimes, when we meet patients with lung nodules, we'll try to create or come up with a percentage of risk. And so there are a whole bunch of these types of models available. You can get them online. I do not recommend that you do this if you're not a physician, or if you're not evaluating and managing patients, if you're just doing this for yourself, because it will just confuse you and can freak you out. But we will use these models to provide us with some guide as to risk. And if it's below 5% risk, we'll tend to be more conservative, meaning that we won't be as aggressive in trying to figure out what this lesion is. If it's above 5%, then it sort of depends on where it lies on the spectrum. We may push for more aggressive evaluation and maybe even biopsy or surgery. So follow-up of these nodules, it really depends on size and your risk assessment. So this follow-up is really applied to individuals who are over the age of 35. We don't really look at patients below the age of 35, because just by age, they should be at low risk for having lung cancer. We're also excluding patients whose immune systems are not functioning. So patients who have cancer and are on chemotherapy, people with HIV, for example, and also people who've had a suspected cancer or a known previous cancer, because they don't really fit into this evaluation scheme. They should have a more aggressive evaluation than individuals who don't have those risks. And the measurements that are provided in the table are based on the average of the long and short axis of the nodule. So you can sort of imagine that a nodule on a CAT scan is a two-dimensional image, and so you only get a slice, a cut through this sphere that looks like a circle. And so what we do is we average two different measurements of that circle to give us the long axis and the short axis, and the average of those two numbers is the number we use for determining the size and to provide us with an assessment of how we follow up patients. Patients who are at low risk, so less than 5%, they're young, they have less smoking history, no prior cancer, the nodule size is smaller, the margins are smooth, and they tend to be in the areas of lung that are not in the upper part of the lung. High risk, individuals who are older, heavier smoking history, prior cancer history, larger size, the margin is irregular, so lobulated or spiculated, and the nodules are in the upper lung. And then intermediate are those individuals who are between, a mix of those two. And you can see here in the slightly gray and white chart, how we manage or follow those individuals. So it's based on size less than 6 millimeters, 6 to 8 millimeters, greater than 8 millimeters, whether they're a single nodule or multiple nodules, and whether their patients are at low risk or high risk for lung cancer. And then for patients whose nodules are not completely solid, there's a whole different algorithm for how we manage and follow those individuals. Periphyseal nodules, I'm going to skip this because we're actually running late. Follow-up issues. So the most important question, or the most important thing that we're looking at, is do these things grow over time? And growth, concerning growth is doubling. And so what we refer to as doubling time really refers to a doubling of the volume of the nodule, not the diameter. So if it's, so people, get misled, especially if they don't do this. They're looking for a nodule that's 1 centimeter in diameter to increase to 2 centimeters in diameter before they get worried. We're worried if that 1 centimeter diameter goes to 1.25 or 26 centimeters in diameter, because that's actually equivalent to a doubling in volume. So if you remember from your high school days, volume is 4/3 pi r cubed, and so a doubling is equivalent to a 26% increase in radius. There are some who theorize that if the lesion doubles in less than 30 days, it can't be cancer because that's just too aggressive. and it's more likely to be some sort of infection or inflammation. And if the doubling time is more than 300 days, it's also very unlikely to be cancer because that's way too long. So that's one type of lesion that we follow. And then ground glass nodules are the other type of lesions that I described. These can represent sort of an indolent or slow-growing cancer, or they could be precancerous lesions, like a polyp in the colon. Or they can represent what we call bronchiolo-alveolar carcinoma. So it's a very unusual type of lung cancer that tends to be slow-growing. And so these types of nodules, remember I said before that if a nodule is stable for 2 years, we tend to at that point in time say that is likely to be a benign or non-cancerous lesion. But for ground glass nodules, we tend to watch these for much longer. And I've seen them out at 5 years suddenly start to change and become concerning for lung cancer. So for ground glass nodules, we tend to follow them for about 5 years before we feel comfortable saying that they're not cancer. Now, if at any time during that period of time, something solid develops within that ground glass lesion, we are very worried about that being a lung cancer. And in some facilities, that is such a strong predictor of lung cancer that they actually don't even biopsy them, they take them straight to surgery. So again, the things that we do at CPMC, endobronchial ultrasound, electromagnetic navigational bronchoscopy, and imaging-guided bronchoscopy or robotic bronchoscopy. This is EBUS, it's real-time ultrasound imaging, permits safe and accurate biopsy of the paratracheal or lymph nodes that are around the windpipe, as well as hilar lymph nodes. Hilar lymph nodes are a little bit further out and harder to biopsy under other techniques. This is the tip of the bronchoscope. This part here is the ultrasound. And this is the working channel that allows us to put a needle out through it. And so this is the kind of schematic. We have the scope up against the airway wall. This is the lymph node on the other side. And then you can see the needle. We actually watch it real time, and this is an image of it. So this is the ultrasound image. This is the lymph node here. And you see this white line going through it. That's the needle going through the lymph node that we're biopsying. And we can be very accurate. In our hands here at CPMC, we're about 99% accurate if we can get that needle into the lymph node for detecting lung cancer if it's there. This is an example of some of the patients I've biopsied. So this is what I call a hilar lymph node. So this is further out in the right lung. This is super bright on a PET scan, so it's very, very active, and this turned out to be a lung cancer. This is a patient who had lymph nodes that under normal circumstances, we would have been very, very scared to try to biopsy because this is an artery here and another artery here. This is the windpipe. So we were able to come down with the scope and actually see where that artery is, and pass a needle right between the two to get into this lymph node. And this turned out actually to be recurrent metastatic spread of breast cancer to the chest. This is another patient with a big mass in the right upper lung. This is the windpipe coming down here. I was able to take the scope and just keep it right here and put a needle into the mass and diagnose small cell lung cancer. This is another patient with a very small, what we call hilar lymph node out here. And again, this is in the left chest. This is the airway here, so the scope is sitting in here, and I was able to biopsy this, and this was also lung cancer. And this is a patient who had prostate cancer with a single spread of cancer to this hilar lymph node here. And so what they asked me to do was to put in what's called a fiducial marker. This is a little gold rod. So I was able to use the ultrasound scope to come down here, drop that into the lymph node, and then the radiation oncologist was able to very accurately provide radiation to this area to treat the patient for metastatic prostate cancer. This is electromagnetic navigational bronchoscopy. This is basically GPS for the lung. This is a little outdated here now at CPMC because our team is now using robotic bronchoscopy. But basically what we do is we identify the lesion in the lung, and then we leave electronic breadcrumbs so that we can then follow a map out to the nodule that we want to biopsy. And you can see here that this is the sort of the GPS marker telling us where to go, and we can literally follow it out to the lesion. The risk of biopsy-induced lung collapse is less than 5%. and it's very effective in helping us biopsy lesions that could be very challenging to go after. So this is one patient I went after with that particular device, and this turned out not to be lung cancer. It turned out to be aspergillus, or a fungal infection in the lung. This is another patient that I was able to biopsy. It turned out to be an early stage lung cancer. This is another patient that our radiologists were a little bit worried about trying to biopsy with a needle through the chest, because this is the big artery, the aorta, sitting here, and this is the heart sitting here. So they were afraid that if they put the needle in too far, they could puncture either the artery or the heart. So we were able to come down with the scope, the electromagnetic scope, and just biopsy this, and that was a lung cancer as well. And this is an example of a patient with a lung nodule in this area. You can't see it very well, but we were able to put fiducial markers in here using the electromagnetic scope to help the radiation oncologist treat that more accurately. So let's start with this one. When a nodule is detected and it's not indicative of cancer, what does it most often due to? Well, it's any number of things. Common things being common, old infection and scarring are the most common causes. But it also depends on what part of the country you live in. Here in the Bay Area, especially if you've been around the Central Valley, then infection is very common from coccidiomycosis or tuberculosis because we have a large immigrant population here. If you grew up in the Ohio-Mississippi River Valley, histoplasmosis is actually one of the more common causes. And then these other three are not really related to lung cancer screening, so I'll try answering these really quickly. Here, long-term problems for children, adults, older adults from California fires. Yeah, I mean, so it's a worry. It's being exposed to air pollution has, without question or doubt, been associated with long-term lung problems like development of COPD, increased risk of asthma. And so, I think that I won't go into a political discussion here, but climate change is happening. And for non-believers, we're seeing it develop in front of us. So this is, unfortunately, I think California wildfire is going to become a season for us. We have our rainy season, we have our dry season, and we have our wildfire season now. So it's something that we're going to have to learn to adjust to and deal with. And then how serious is COPD and how common is it? So COPD, I can't remember if it's the third or fourth most common cause of death in this country. So it's fairly common, but when you look at the numbers, it's about 4% of U.S. males and 3% of U.S. females have COPD. But COPD is sort of a big basket term. There's a huge number of patients with COPD. I think the number was about 17 million when I last looked. But that the range of severity of COPD is quite broad. So there are individuals with COPD who are asymptomatic. They just happen to have imaging which raised the specter of COPD that then prompted our breathing tests, which is how we diagnose COPD. And then they're found to have COPD, but they just don't have any symptoms from it. So it can be serious, but it can also be very, very mild and not cause any symptoms. So, but I think that if we all focus on lung health, and this sort of ties into the other question about the harms of vaping and smoking cigarettes. Lungs are just, they're unfortunately a fantastic way of getting drugs into our system. And because of that, because it's an effective drug delivery system, it leads to abuse. Leads to smoking, vaping, e-cigarettes, as well as, smoking crack and smoking meth. So there's, and smoking marijuana. So I think that, you know, though people have claimed that vaping is safer for you or somehow healthier for you than smoking cigarettes, I think we've seen that there are a number of unique diseases or lung damage that occurs with vaping that we never saw with cigarettes. So I think that anytime that you're introducing something to your body, you have to question whether it's actually a good thing to be doing. And so, you know, I think that the harms of vaping are different from the harms, in some ways can be different from the harms of smoking cigarettes. And vaping is so young or so early in its uptake by the population that we may not know for 10 to 20 years what the true harm of it is. So to somehow listen to individuals out there who are claiming that it's healthier for you, I'm not sure that I would necessarily buy into that information. So I think that's it for now for questions. Does anyone else have questions that they would like to voice?
I think that there's another question that came in through the Q&A. It's just a question that asks, what about diesel fumes?
Yeah, so diesel fumes, I actually wrote a paper about this a number of years ago. So there are concerns about diesel fumes. You know, it's just like any other type of air pollution, that there may be an increased risk with malignancy and also other types of lung disease, but it's a little bit hard to quantify as with any of these because it's really hard to do good clinical studies. You can't really tell people, hey, how about I expose you to diesel fumes and then this group of people I don't expose to diesel fumes and let's see how you do. That would be very ethically, that would be a very unethical study to try to propose, but there are concerns about it.
Is there particulate matter in diesel fumes?
Yes.
Great. Not great, but thank you for answering that question so quickly. All right. Well, I thank you everyone for joining us, and thank you again, Dr. Chen, and I will see you all hopefully in a few days, but have a great evening.
You too. Thank you.